This is No Operating Manual, a podcast about building healthcare companies when there's no one clear path and no operations manual.
My guest today has spent nearly 2 decades moving through almost every corner of the healthcare industry, most recently building platforms and products for large integrated health systems. Now he's president of Practice with Joy, a company built on the belief that primary care can be more accessible, more sustainable, and more joyful. The model pairs nurse practitioners with AI technology and operational support to create a new kind of primary care platform. Chris Bane, welcome to No Operating Manual.
Thanks, Erin. Great to see you again. Thanks for having me.
Let's jump right into it. So first off, tell me a little bit about why you launched Practice with Joy. What did you see in the market that told you to build around nurse practitioners and, using that as the core of primary care delivery?
So Joy solves essentially at its core a supply and demand problem. So on the demand side, you have, as many listeners probably will know, a primary care shortage around the country, right? So about 77 million Americans live in what you would call a primary care shortage area. The American Association of Medical Colleges projects a 50,000 person PCP shortage by 2030 or so. So you can imagine what that means in terms of long-term health outcomes for folks around the country. And then on the supply side, you have nurse practitioners as the fastest growing healthcare role in the country. And more recently, regulation momentum around giving those nurse practitioners what is called full practice authority, which enables them to practice medicine without an MD sort of looking over their shoulder on a day-to-day basis. So they have a lot more operating freedom now than they ever have in most states in the country. So you take those two kind of supply and demand data points, you put them together, right? You have full practice authority now meaningfully on the horizon. And then what you have at the same time is our belief that technology can now meaningfully impact both the underlying cost structure of running an NP-led practice and also enable nurse practitioners to earn value-based reimbursement on sort of the revenue side of running a practice. So essentially reducing the cost structure of running a practice through automation and technology, and then expanding their ability to drive revenue by delivering high quality clinical. And so when you put all those ingredients kind of into the recipe, what you have is Practice with Joy, which our mission is to deliver the highest quality NP-led primary care in the country.
So getting into the nitty-gritty details, because I don't know how that reimbursement model works. Are NPs reimbursed at a lower rate? Or how does that work for primary care or doing very similar primary care things than an MD would?
Yeah, typically, if you look at sort of the Medicare reimbursement rate fee schedule, NPs are reimbursed at about 85% of what an MD is for the same procedures and activities. And oftentimes commercial payers will sort of follow suit in terms of similar reimbursement structures anchored on that Medicare arrangement. And this doesn't happen everywhere, but so oftentimes you see NPs are reimbursed at a lower rate, which does make operating a clinic all the more challenging. We know running primary care is challenging as it stands today with reimbursement where it's at for MDs. And then when you take a 15% haircut on top of that, it makes it all the more challenging, right? So that really lays out Joy's challenge of needing to find that 15% by compressing the cost structure or the admin overhead of running a practice, and or finding a pathway to incentive-based reimbursement through things like value-based contracts.
Yeah, that makes more sense. Just making sure that it's clear that your AI product is called Joy, correct?
Correct. We call it the Practice Operating System or Joy Practice Operating System. It's really intended to help an NP run the practice from end to end. So the components underneath that are the front end. So we have sort of a patient relationship management module where we engage with patients. We have, of course, a certified EMR product in the center that handles the clinical visit and the reimbursement side. And then we have some tools supporting RCM. We also provide some wraparound support to those NPs. So that means things like credentialing. We have folks who do that on behalf of our nurse practitioners because that's just something that takes up a ton of administrative time, and it can be super frustrating if you're not an expert on that as well.
Got it. AI in healthcare has been promised as a solution to burnout and that administrative burden that you're talking about all that time. But clinicians have heard a lot of promises before. How do you earn those NPs' trust as you're moving forward?
Yeah, we think, trust is earned kind of the same way it always has been, which is by doing the unglamorous work really reliably every day. And so a lot of that goes into how we think about deploying AI. We're very thoughtful about where it does and doesn't say belong in terms of the operational and clinical workflow of delivering care. And when we do deploy it, we're very conscious of what it takes to train the large language model or the agent so that there are A, guardrails, and B, it's a well-trained model such that it's predictably providing an output that is correct. It's very important with us that to us that we keep the clinician in the loop at all times as well. So the AI is really what it's doing is synthesizing and compressing information and presenting clinical data points to the clinician. It's really so it's an enablement layer more than a decision-making tool, right? So it's presenting that to the clinician such that he or she can make the right decisions in a compressed time frame. And that's really kind of where it stops from our perspective, because we really want the NP, the nurse practitioner, to feel empowered in her clinical decision-making. And also our goal is to ensure that she's able to spend as much time with the patient as she can or wants to. And so the technology and the AI is enabling that as well.
Speaking of AI, it's obviously being built into every aspect of healthcare. How has it changed, AI changed how you're building your company now versus maybe 5 years ago?
Yeah, I think things are changing almost every day here on sort of how we engage with AI from a perspective of building the company. So we use agentic coding support, right? And so that means that our shipping velocity of shipping product is higher than it's ever been. And we're doing more with less just from a headcount perspective. To build the platform that we've built would have taken 30 engineers, 2 years kind of thing a few years ago. We're able to do that with 5 AI powered engineers who are using coding tools and other utilities that just enable them to do that much more, that much faster. That includes things like running test cases, something that you'd have to hire a QA engineer to do. We don't have to do that anymore. So things like large language models are excellent for that sort of thing. And then also we're able to build internal utilities to support some of our operational staff as well. So that's, startups are all about doing more with less. And it's super helpful to us to be able to build a credentialing utility that we can hand to our operational staff who are doing the credentialing for our NPs and really help them do it 10 times faster. And so there's a number of things sort of on our internal utility roadmap that we're building as well, so that Joy as a startup is able to stretch our dollar as far as it can go as well.
You describe yourself as an operating system for high quality care.
Yes.
Using that AI layer, you're talking about how you are, integrating that into the NP's existence within the practice. But what does that really mean in practice, the operating system for high quality care? How do you make sure that that operating system is equating high quality?
Yeah. So I think a couple principles that we think about when we talk about the intersection of technology and AI and delivering primary care, let's say. So one is in terms of the clinical workflow and the patient visit, the technology should really fade into the background, right? So our goal, if you can imagine 10 years from now, you're sitting face to face with your nurse practitioner. There's an ambient scribe listening to your conversation. There's really no screen in the room at all. There's no need to capture clinical documentation for risk adjustment purposes because that's all being done in the background. And so what you have is just a really nice face-to-face conversation, and the orders are being fulfilled and then signed off on by that clinician after the visit. But there's no sort of technology interfering, or there's no pane of glass between the patient and the clinician. So we kind of think about we're building towards something that looks a lot like that to really bring value back to that encounter. And then from an operating system perspective, what that means for us is really kind of 4 layers. You have the clinical layer, right? So you have evidence-based workflows. You have that ambient documentation capability. We surface care gaps. We think about what value-based care scorecards need to look like based on the types of payer contracts our NPs are engaged in, right? So we're surfacing all of that in the background, making sure we're fulfilling on those incentive structures. And then you have an operational layer, right? So you have scheduling, billing, credentialing, patient communication. That's sort of the wraparound admin support and automation that we provide. You have a business layer, right? So how am I doing from a panel growth perspective? What does my payer mix look like? Meaning how much commercial, Medicare, Medicaid patients do I have on my panel? What is the profitability of my clinic? So that's sort of the business module within the platform. You have, what we think about as joy or well-being of the clinician. And so not only do you think a lot about patient experience and patient satisfaction, but the nurse practitioner is our customer as well, right? And so we think how do we bring joy to practicing medicine again? And it's by doing well the things I just laid out across operational, business, and clinical. If we can extract the administrative burden away from those things and really enable valuable clinical conversations and enable NP to run a practice with high autonomy in her own community, then we think we're bringing joy to that nurse practitioner.
You listed all these types of patients that the NPs can engage with, whether it's Medicare or a typical, commercial member, whatever. What happens, or how does it work if a patient does not want, in their care room with them? Has that been thought through? I'm thinking recently about two experiences I had in healthcare. One where the doctor said, "Hey, this is the system I use," and another one who just didn't even bother, and I knew that he was
Yep.
using it.
Yep.
So I'm just curious how that works.
Yeah, it's a little bit of a brave new world out there, especially for patients who might not be aware of some of the emerging breakthroughs in the way medicine is being practiced today, right? So we think about that in the same way you might plan for what happens if the power goes out in a clinic, right? So you have sort of this a series of backup layers, right? So if a patient would prefer not to have something like an ambient scribe running during the encounter, we can turn that off. The NP is able to take note, and we have sort of shortcuts embedded into the medical record. So she's taking notes quickly, and issuing orders and doing all the normal things that she would be doing as well. And so it doesn't really change the outcome of the visit in terms of what the plan and assessment are for the patient or what the orders or the clinical documentation looks like. But it is something that the NP needs to be prepared to fall back to, right? So they still need to understand how to capture the clinical note, how to do the charting. But we're hopeful that this is sort of an 80-20 at least rule, where we think 80% plus of visits would really be kind of have the ambient technology running and take advantage of other technologies that are kind of layered into the operating platform that are really transparent to the patient as well.
So in terms of that, like in 5 years for primary care, Joy is out there,
Yeah.
in the world. What does that look like for patients and for traditional primary care MDs? Like, how do you see that evolving, or does it evolve their experience at all? And how does that change how primary care is
Yeah.
delivered?
Yeah. If you think about the future of primary care, we think nurse practitioners are very well positioned to deliver high quality primary care, right? And if you think about how technology can supplement the encounter or clinical decision making for a nurse practitioner, we think that creating more front doors of care via NP-led primary care is kind of the right thing to do and the right mandate. I think specifically for what joy could look like in, say, 5 years, we like to invest in communities. And, everybody says healthcare is local. It's true, right? So we think about where can and should joy invest in terms of creating market density around delivering NP-led primary care. We prefer to engage in a community and create multiple NP-led primary care practices in, say, a metro area or a rural market versus sprinkling one in every state kind of thing. So that allows us to make a community impact. And we do hire NPs from their own communities, right? That's very important. They want to stay there. They want high autonomy. They can get that in their own community, and joy can facilitate that. And so I think for a patient, it looks like sort of the opportunity to have same day relationship based primary care. A nurse practitioner who knows you as a patient can text with you, engage with you in whatever sort of communication mode that you prefer. And then also do that at, a price that's lower than what an urgent care or specialist visit would cost. And so it's primary care that actually feels like the relationship that it's supposed to be, or that it used to be, kind of a long time ago, right? For MDs, now, what does that mean? I think the honest version is independent physician practices have reduced significantly over time, something like 60% reduction in independent primary care from 2012 to kind of today.
60%, that's a lot.
I don't think that trend is going to J curve back.
Mm-hmm.
And so what does that mean is that what survives is independent primary care inside an MSO model like ours, perhaps. And so maybe a lot of MDs stop doing primary care or go into the hospitalist or the employed health system setting, which is where we see a lot of inflow today. And so we think that if you think about MD-led primary care, there's sort of a vacuum being created in the market, right? And so we think that NP-led primary care is well positioned to fill that vacuum, essentially.
Do you think that there is going to be a point in time where the service is the point of payment? And I'm saying this wrong, but where it's not whether an MD or an NP perform, that particular care. It's actually just the fact that it's being done and then it's actually paid at the same rate. I mean, is that eventually going to be the case? Do you see that happening?
I do. It's really interesting. It's very sort of, it's market by market. We've obviously had a lot of conversations with payers in a lot of different states and markets, and it varies significantly, right? And so there's some states that already pay at parity between MDs and NPs, which we love, obviously, right? And then there's others that are just a little bit further behind on that payment schedule. So I do very much think that there's momentum around creating parity there on the fee schedule between NPs and MDs. The other opportunity is that when networks or contracting entities like clinically integrated networks engage in payer contracts, they often have a value-based component to them. And so that means shared upside if you create downstream medical cost savings. A lot of those are agnostic to who's creating those savings. And we love that as well, because we think we'll be able to demonstrate that NP-led care can create total cost of care savings, and therefore will participate in those shared savings models in the same way that an MD would. So we're really excited about participating in value-based care because we think it further closes that wage gap, if you will, between NPs and MDs.
Does Joy work, like if you were just to sell Joy off the shelf to
Mhm.
other clinical, like is that something you're looking at longer term? Or are you really focused on how do you create these models with NPs?
Yeah, I think our first order of business and sort of the beating heart of Joy is to deliver high quality nurse practitioner led primary care. And the platform should enable that and does enable that. Right. And so that's mission one. If we're accomplishing that mission and we're finding that the platform is really moving the needle on that, like we expect it to, then I don't think there's any reason we shouldn't look at what giving that platform to other folks who might want it can do. Right. If the mission is really to deliver high quality care, then the platform should go out to other groups who want to use that to accomplish that mission. So we have sort of our immediate goal and the mission of the company, but software is software. It can sort of expand with zero marginal cost in a way, right? So we're open to the idea of what it means to expand the Joy operating system to other clinicians in the future.
Well, and also helps keep them independent or as independent as possible, right? So that's also, the goal of Joy.
Of course, the independent physician, oftentimes they roll into the employed health system setting because running an independent primary care practice is very challenging, right? Especially in rural markets. And so if Joy can help on that even a little bit by reducing the administrative expense of running that independent clinic, then I think we've done something good. And that makes a lot of sense. So we're thinking about that a lot.
The page a little bit. You have been a consultant, an investor, and an operator. Which of those lenses do you find yourself reaching for most in this role?
Yeah. The change hats sort of almost hourly, it feels like, in this fast changing world. But it's something like, you're kind of an operator every day. To me, that just means execution, right? So a bias for action, the ability to make decisions with limited amounts of information and data, right? That's just the operating model that early and growth stage healthcare startups are in. I think from an investor perspective, at a minimum, you're thinking like an investor every quarter, right? From a board meeting perspective, but really more frequently as you're shaping the narrative of the business, the strategic narrative, and creating strategic cohesion and clarity amongst the team, right? The team of operators, they want to understand that we're all running toward the same goal. So thinking like an investor, both to synthesize the story and tell it to external investor partners or internally to the team. I think that's a good sort of way to think about the investor hat. The consultant thing, I think that role for me was always rooted in empathy. I think good consultants are very empathetic to the challenges their clients are facing. And so you can imagine empathy being a really important tool to bring to nurse practitioners who are really struggling with burnout, right? Or to patients who can't get to a primary care physician because it's 45 minutes away and maybe they don't have transportation, right? So I think empathy plays a role in that consulting sort of mindset of using empathy to help drive the problem solving, plays a big role in sort of everything that we do at Joy.
You spent years building products within large integrated or for large integrated health systems. And those are the organizations that Practice It with Joy has to work with. Does that change how you approach those relationships now, or does it build off of those relationships?
I think it builds, and I think it comes from an understanding of what's important to health systems and to health plans, just being in that ecosystem for so long. I think that sort of everybody believes that incrementally new primary care brought to a market is a good thing, right? There's obviously a lot of detail underneath how to do that well, but that usually is the catalyst for interesting conversations with health systems and health plans, right? I think the other lesson to take away is that health systems move at the speed of trust, not technology. It's so, a lot of what we do is engaging in conversations about what's important to them and then continuing to build trust about the reliability of our platform, our ability to bring nurse practitioners into a market and deliver high quality care. So obviously measurement of outcomes and being able to speak to those and stand behind them is really important when you're building relationships with large health systems in a given market. Maybe the other thing is, health systems, payers, they don't really need another platform or another point solution. What they're looking for is to solve my problem, right? And we know the problem, right? We can solve it by delivering clinical supply. I think that's more interesting to them than trying to necessarily talk about point solutions or AI solutions.
Yeah, they're trying to solve that or the healthcare crisis of not having
That's right.
enough providers.
That's right.
So with that, like where have you launched thus far, or have you launched thus far in markets? Where is your focus right now?
Yeah. So, when we started early on at Joy, we had tons of conversations with nurse practitioners. We actually just published this research on our website. Had more than 150 conversations with NPs about what was important to them. How, did they want to practice with autonomy? Just trying to get a sense for what product market fit could look like, if you will. And so we in doing that, we helped a number of NPs launch their own independent practices as coming out of that research as sort of our first wave or first cohort of NP-led care. Since then, we've also started an employed medical group, so our owned medical group of Joy, where we will employ NPs and put them on the platform and work with them to develop the clinical workflows and deliver primary care in a brick and mortar hybrid setting, telehealth and brick and mortar. So that's been our most recent focus. And that's where we're deploying in a number of markets on the East Coast and also looking at the Midwest specifically for rural markets, where we will partner with health plans, health systems to deliver care in primary care deserts, if you will. And so we're super excited about that. We now have sort of a deployment playbook where we can come in and recruit, stand up that brick and mortar clinic relatively quickly, right? Drive credentialing with high reliability. And so I think stamping out, continuing to exercise that playbook and stamping out medical group clinics is going to be our focus here in 2026. We're really excited about that.
I love that, especially that rural reach that is so necessary right now. Kind of wrapping this all up, what advice would you give other founders building new healthcare companies right now?
Yeah, I think it's a great question. Maybe I would sort of favor flexibility over rigidity. And so there's a lot of unknowns when you start out trying to solve healthcare problems, whether that's sort of regulatory burden that you didn't know existed or sort of market dynamics, maybe that you weren't as intuitively aware of. And so there's going to be problems and road bumps, I think, that come up. There are sort of every day for us at Joy, right? And so the idea is, how do we flex? How do we work the problem, if you will, right? While still maintaining adherence to the core mission, right? So I think it's that flexibility, but paired with mission discipline of what is the beating heart of the business? Well, it's deliver super high quality primary care that's led by NPs. If that's still our North Star, then we can still be flexible in solving our tactical day-to-day problems, but while marching toward that, right? So I think it's, when I mentioned sort of strategic clarity, I think it's having that North Star, having everyone on the team sort of marching toward that objective, but also enforcing sort of independent thinking and problem solving, using agentic tools to solve problems is kind of a new thing we're all doing, right? And so I think that flexibility is very important at this stage in the game for healthcare founders.
Flexibility, kind of go with the flow.
That's right.
Chris Bane, thank you so much for taking the time to share your story and experience. We look forward to seeing what happens next with Practice with Joy.
My pleasure. Thank you, Erin, for having me.
Thanks for listening to No Operating Manual. If you enjoyed this episode and you'd like to support the podcast, please leave a rating and a review, and don't forget to subscribe on YouTube. No Operating Manual is hosted and produced by Erin O'Brien of Chemistry, a healthcare marketing and communication advisory. Visit our website at choosechemistry.com.